Um, would you please share your slides so we can be sure everything is working before we start, please? Yeah, fantastic. We can see everything now. The invisible guest. Yes, and you have used the first slide of the film itself, the Spanish film. Do you hear me, Prof?
Oh, yes, I can hear you. Yeah. Sorry, I was muted.
Mm-hmm. What do you think about selecting such attractive topics? I mean, like the invisible guest, like Wonderland, like.
I think it's very nice.
Thank you. So, dear attendees, dear audience, Professor Liu is asking about the feedback about his first lecture, the opening lecture of the series, the overview of the Wonderland. So would you please put your feedback in the chat so he can see the feedback, please? Usama says, thank you very much for every information.
I don't think I can see the chat.
You can't see the chat?
No, but it doesn't matter. It's okay.
Do you see the icon of the chat at the bottom of the screen?
No, I think now that I'm sharing screen, I don't really see it anymore.
Maybe yes, because you are sharing. Okay, I think, yeah. Now, another one wrote, it was very good. Thank you, Prof.
Oh, I can see the chat now, yes.
Mm-hmm.
I can see it now. Yeah, thank you.
Mm-hmm. Okay, I think we can now start because it is 1:10.
Okay. So can you share my screen again?
Yeah, you can share. I think we can see your screen now.
You can? Okay.
Yeah, we can. Yeah. So, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody, and welcome to this session in the Cornea series, the journey to the Wonderland. And today, Professor Christopher Liu is going to tell us about the invisible guest, who is very, very delicate, but might be very, very dangerous and harmful. So we can't wait to learn from Professor Liu, and the stage is yours, Professor. Thank you very much for accepting the invitation and for being with us in all the series. Thank you very much.
Thank you very much, Professor Masson. So my brief this evening is to talk about the invisible guest, which is contact lens complications. Of course, you know the film The Invisible Guest, actually originally a Spanish film, but I can think of another film with an invisible guest. That's Harry Potter with his invisible cloak. So nice. I would acknowledge that I don't have any financial interest in the field of contact lens. And I very much thank Andrew Gasson, who's written this book. And many of the images are from this book. And also to my mentor, Professor Roger Buckley, who is a contact lens specialist. He is part retired now. And in fact, in the early part of September, I will be reading his citation when he becomes an honorary fellow of the Royal College of Ophthalmologists, which is the highest honor the Royal College of Ophthalmologists can bestow to anybody. I want to go back to my opening talk and just revise a little bit about infectious keratitis, mean, obviously, this is really the major complication of contact lens wear. So the risk factors of infectious keratitis, contact lens wear, ocular surface disease, trauma, and topical steroids. In terms of contact lens wear, soft lenses will be riskier than rigid gas permeable lenses, and extended wear, meaning day and night wear, will be riskier than daily wear, which is just wearing during the day. So showering and swimming with contact lenses in place should be barred or discouraged, because that really increases the risk of infectious keratitis, especially acanthamoeba. Now, even if you're very, very careful with hand hygiene and lens hygiene, including daily disposable lenses, you cannot completely avoid the risk of infectious keratitis. These are slides from my opening talk. The etiology include different bacteria. And here you see a Pseudomonas swimming about. So it could be gram-negative or gram-positive. It could be fungal, it could be amoebic, and many other agents, in fact. So can we tell anything from the appearance? You will see some more examples, but if you have very small peripheral lesions without any anterior chamber activity, they may actually be sterile infiltrates associated with contact lens wear. However, you should have a very high index of suspicion with contact lens wearers. Clinical appearance is actually not reliable for etiology. So fungal keratitis may have feathery edges and satellite lesions. Radiokeratoneuritis, which you can see here and here and here, that is said to be pathognomic or diagnostic of acanthamoeba keratitis. And herpes simplex keratitis can mimic and is very much overdiagnosed in clinical scenario. So this is, again, a slide from my opening talk, just as revision. Remember the approach to bacterial keratitis summarized in this slide. You do a corneal scrape for microscopy, culture, and sensitivity. And gram stain can give you a clue to the agent. And don't forget, there may be more than one agent which is infecting. If severe, admit the patient, because they will need round-the-clock, hourly antibiotic drops, and patients can't manage. On the whole, they can't manage overnight drops. They might set the alarm, and eventually they get so fed up, they will throw away the alarm clock or just switch off the electronic alarm, and they cannot manage overnight drops. Just to begin with, usually monotherapy with the fluoroquinolone, such as ofloxacin or moxifloxacin or getafloxacin. Then don't expect any change in clinical appearance before 48 hours of treatment. But the patient can tell you the following day or even a few hours later whether they are feeling better. And if the patient feels that there's improvement, there is usually improvement. So you should ask them and you can trust them. Now, if no response, then consider rescrape, stepping up the treatment to fortified cefuroxime and gentamicin. If you're considering a rescrape, then you should stop the antibiotics for a day so the bacteria can become more lively, so you can grow them again. If you scrape while still on antibiotics, the yield is going to be low. What about keratitis? Here are some confocal images of cysts. So I think then you need to have a high index of suspicion, especially if there is disproportionate pain. To begin with, acanthamoebic keratitis will give you epithelial irregularity. Then there are infiltrates at different depths and different size. And you've already heard about radiokeratoneuritis, and confocal can help. If you need to take tissue, the first bit of tissue to take is to remove a sheet of epithelium for microscopy and culture. Now, for culture, you need to plate that onto E. coli seeded non-nutrient agar. Normally, the plating is first done on non-nutrient agar, and then the laboratory technician may spray the plate with E. coli. If they supply you with a plate of E. coli preceded non-nutrient agar, there's always a risk that the E. coli can get into the eye if you're not careful. Early diagnosis of acanthamoeba is very important, and it really improves the outcome, including not having to do surgery afterwards. And as I said, acanthamoeba is very much misdiagnosed as herpes simplex keratitis. Half the cases are misdiagnosed beforehand. And I know some people talk about throwing everything at acanthamoeba, but monotherapy, either with PHMB or with chlorhexidine, depending which is available, gives the best outcome. And of course, no steroids. Steroids should only be used in acanthamoeba when there is uncontrollable anterior chamber inflammation or scleritis. And you can see here an interview with Professor John Dart, who is the guru in acanthamoeba keratitis and many, many other topics, corneal topics. So again, fungal keratitis, this was covered in my opening talk. And here you can see basically the hyphomycetes and yeasts, and principally Candida, and you've heard these other names, Aspergillus, Fusarium, and so on. Now, here you see a corneal graft and a loose suture here, and together with a long-term steroid, has precipitated this infection in the corneal graft. So this is the talk on the 2nd of May, which is still on YouTube, hopefully forevermore, if you wish to go back and revise. Now let's have a look at the effects of long-term contact lens wear, which is today's brief. And some of it is clinical, a lot of it is academic, and which this may or may not interest you, but you may not hear it from elsewhere, so you may as well have a look at some of these slides and the photographs. Now, how does the contact lens work? Contact lenses are mostly used for correction of refractive errors, and the front surface, the front optical surface, then acts as the refractive surface and replaces the refractive power of the anterior cornea. The back surface of the contact lens and the front surface of the cornea is interfaced by a tear lens. And because the contact lens refractive index and the tears and the corneal substance are very similar, then you can consider the whole complex as one optical element. So that is how refractive error is corrected. And that is also how irregular cornea is helped by use of a contact lens, especially a rigid gas permeable contact lens. Now, another use of contact lens is therapeutic contact lens wear, and that is what is commonly called a bandage contact lens. A bandage contact lens or a therapeutic contact lens can actually be a soft lens or a rigid lens or even a scleral lens. The principal function would be to protect the cornea and promote healing. And it can maintain hydration, helps with epithelial healing, and also heal small perforations. If there is no tissue loss, the stroma will become hydrated and it will seal itself. However, a contact lens is nevertheless a foreign body. It is something which naturally should not be on the eye surface. And that is how it causes problems, by being a foreign body and by causing microtrauma, actual trauma, and causing some degree of hypoxia, especially if worn overnight and if patient accidentally falls asleep. The relevance of contact lens in myopia, obviously it can correct myopia, and it can be daily wear, daily disposable. It can be a rigid gas permeable lens, and you'll see many examples in ensuing slides. I've already talked about the importance of hand and lens hygiene, and on the whole, it is really best to avoid extended wear. There's only one exception, and we're seeing it less and less, and that is patients who've had cataract surgery. In the olden days, they didn't get an implant, but the majority of these patients have already had secondary implants or passed away. In those days, you can have extended aphakic contact lens, and for whatever reason, when there is no lens in the eye, crystalline lens, oxygen flow seems to be better, and there is very little incidence of infectious keratitis. Orthokeratology is a separate field altogether, and that is nighttime wear of rigid lenses to mold the cornea, to give a different shape and also to flatten it, especially in children, to treat myopia and to reduce progression of myopia. Now, what about the effect of contact lens on cataract surgery? It is important to distinguish between molding and warpage. We don't see warpage anymore. Warpage is when you wear the old style hard contact lens were made of PMMA, when long-term hypoxia actually changes the shape of the cornea, and it takes several months for it to recover. Whereas molding is simply the cornea taking up the shape of the contact lens. So if you're doing biometry for cataract, if it's soft lens wear, you should take the lenses out for 1 or 2 weeks. If it's rigid gas permeable lenses, then you should take the lenses out for 2 or 3 weeks. The longer, the better. Now, the other relevance is in actual or trial of monovision. So if somebody has been used to monovision contact lens wear, then you can simulate that with implants, and that is one way of giving them spectacle independence without having to resort to more expensive and riskier multifocal implants, which always give some degree of glare and halos. Now, if you are a trial of monovision, you can also do that with contact lenses, and you try that before giving them monovision with intraocular lenses. Now, it's good if the lenses are quite clear and you're just thinking about refractive lens exchange. However, when there are cataracts in place, then trial of monovision may not be so successful because everything is already a bit blurred. Finally, in cataract surgery, with contact lens where the flora on the ocular surface is altered, so it is better if for at least 24 hours before cataract surgery not to wear contact lenses, and you have a better chance of avoiding intraocular infection. So let's get to the meat and the academia and the clinical scenario of contact lens intolerance and complications. Now, contact lens intolerance is a loose term, and it is a symptom. For example, it could mean increased awareness of the contact lens, instability or loss of lenses, a sensation of dryness, reduction in daily wearing time, impaired vision, redness, watering, and discharge. When we talk about complications, these may be asymptomatic. For example, staining of the conjunctiva, the limbus becoming reddened, superior epithelial arcuate lesion, epithelial vacuoles and bullae, stromal edema, stromal thinning, long-term, and neovascularization, which can be superficial or deep. Then you can get acute endothelial blebbing. You can get long-term cell loss from long-term wear. Also, the shape and size of the endothelial cells can also change with chronic contact lens wear. And I'll show you these. Now, because contact lens related symptoms are rarely diagnostic and contact lens related complications may be asymptomatic, if you are looking after contact lens wearers, they should have a slit lamp examination every 1 to 2 years. And more often in certain conditions, such as keratoconus, post-keratoplasty, and where there is reduced corneal sensation. For example, in cases of herpes simplex or zoster, when there is reduced sensation. Remember, with a contact lens in place, you cannot actually examine the cornea adequately. You think you see the cornea, but you don't see the surface and you don't see the details. So always examine the eyes with the contact lenses in place and then remove them to see what's underneath. If you just look with the contact lenses in place, you have not really done your job properly. Now, what are the effects on the front of the eye? Look, you got your upper lid, your upper fornix, lower fornix, lid margins, and cornea. The first thing to remember, you can reassure patients because they always say, oh, I've lost my lens. Do you think it could have gone up here and then gone into my brain? Of course, it's not possible because you've got the upper fornix and it's a dead end. How can it affect the eye then? So for the lids, you have a change in lid position and lid movements. Very often there is reduced blink or incomplete blink, and the marginal structures, the meibomium secretions can be affected, and also blepharitis can also increase in the sense that with lenses in place, they might be less inclined to clean their lashes. Tear film changes, I'll show you example. Conjunctival changes, both on the eyeball and at back of the upper lid. Again, I'll show you examples. Changes to the limbus and actually changes to all layers of the cornea. We will see. So let's have a look at the lens, contact lens itself. So you can have loss of lens from poor fit. The lens may be too loose, and the edges may come forward, and the handling may be faulty. Physical damage, torn lenses, chipped lenses, scratch lenses, and bits of lenses missing, and foreign body underneath the lens, especially with rigid gas permeable lenses, and that would really scratch your cornea, and I'll show you examples. And of course, various deposits, protein, lipid, calcium, and deposits are usually worse on soft lens material compared with rigid lens material. So here you see a flat fit, and you can see that this edge is lifted, and of course it's uncomfortable because the lower lid now feels this edge, and it's more it's easier with blink for this to be lifted further and for the lens to be lost. So fit is important, and to be honest, I think with soft lenses, the fit is already very easy. So if the fit is not all right, then you just try a different one, and it would be all right. Basically, you want about a 1 millimeter movement, and you want all the edges to be in touch with the limbal conjunctiva, and there should be no blanching of the limbal vessels. If there were, then it's too tight. And here you have too steep, and this is a post-graft eye, and it's irregular, and you see this here because it is not fitting. It just doesn't touch the eye on this area, and it's lifted, and of course it's uncomfortable, and you can lose the lens, and they may not see as well either. And here you see too steep, and you've got a lot of fluorescein inside, and in fact this area doesn't even fill with fluorescein when you're assessing the fit, and it's filled with air bubbles, and this will not be comfortable, and where the air bubbles are, it will leave indentation on the desiccated epithelium underneath, so-called dimple veiling, and I will show you examples of that. And here you have a lens which is going to the wrong place. And in order to make it better, then you will need to make it larger and a little tighter. And here, look at this. This a little bit missing here. and the patient may not notice it, but it will be uncomfortable. And here is a torn bit of contact lens underneath the upper lid, and you can see it's been stained with fluorescein. And I remember reading in the BMJ that the record number of contact lenses lost in the upper fornix, I think about 30 lenses. So it's lost, and then you put another one in, and it's lost again and put another one in. So be careful and do eversion, and if necessary, you can use a cotton bud to go underneath here, or even do double eversion, and you might be able to find lens fragments. I have seen a patient a couple of years ago, and she's been to see many, many doctors and to the eye hospital casualty department as well. And she keeps saying, it's uncomfortable, and I've got discharge. And I fished out a small bit of contact lens, and she was ever so happy. So you can also be that doctor to make the patient happy. Another bit of chipped etch, and this is a rigid gas permeable lens. See the scratches here, these lenses, you know, they need to be replaced. You know, even rigid gas permeable lenses, they need to be replaced every year. Otherwise, they get scratched like this, especially if the user, the patient, is very rigorous with the cleaning and the scrubbing with protein remover and so on. And you can have foreign body tract, as I said. If underneath you trap a bit of foreign body, you can have all these scratches, and it will heal. And you give a bit of antibiotic to prevent infection whilst it's healing. So deposits can come in different forms. You've got these bits of calcium on the contact lens, and lipid on calcium acetylbutyrate. The contact lenses are not really made with this material anymore, but you just, I mean, you can get little bumps here, and here you have a more a thin film of protein, and it makes it uncomfortable. They can get giant papillary conjunctivitis as well, and of course they don't see as well because it's not clear anymore. And here you got a combination on the lens surface, and they look like jelly bumps. So in terms of lid, I've already talked about abnormal blinking, and more often than not, with contact lenses in place, the patient will blink less, and they may not do a complete blink. They may do a flick blink. So you have to teach them how to blink completely. Otherwise, there'll be a strip underneath about here, which doesn't get wiped. So the other thing is, with very long-term contact lens wear, especially with hard lenses, you can get mechanical problems, and later on they can get a mechanical ptosis, which then will need to be fixed, fixing the levator aponeurosis. And that, of course, needs either you're trained in it, or it might need to go to an oculoplastic surgeon. And you can get increased blepharitis as well. So here, if you get an incomplete blink, you can get staining on the lower parts of the conjunctiva. And here's just a stamp showing ptosis, just as a reminder. And anterior blepharitis, which was fully covered in my first lecture in May, and posterior blepharitis with plugging. And of course, you can study with meibography as well and see whether the meibomium glands are still functioning or blocked. So now, what about the tear film then? On this first slide, obviously you're going to get a pre-contact lens tear film, which is the tear film in front of the contact lens front surface, and then the post lens, which is the tear lens between the posterior surface of the contact lens and the anterior surface of the cornea. The pre-lens tear film is naturally unstable because your normal lipid layer and mucus layers simply do not form. And that would the lack of normal lipid layer increases evaporation, and this happens in all lens types. So all lens types will add to increase evaporation or further drying of your eyes. So don't imagine that by putting a contact lens in, you're hydrating the eye. Never. it sponges the water and evaporates it, okay? So the volume of tear produced is unaltered. However, with rigid contact lenses, you will get a hyperosmolar tear film, and also in extended wear soft contact lenses too, but not in daily wear soft contact lenses. And if you use a tear scope, it shows the interference fringes in specular reflection. In this second slide, I just briefly tell you about mucin balls which can form under the contact lenses, especially silicone hydrogel lenses. It was first reported 21 years ago now, and usually symptomless, and they are 10 to 50 microns in diameter and do not move with blink. And these will leave epithelial pits on lens removal, but they resolve within hours. Both mucin balls and epithelial pits will stain with fluorescein. Here's just some examples of silicone hydrogel lenses. And here you see some mucin balls underneath the contact lens. On this third slide about tear film, we continue with mucin balls, the differential diagnoses, epithelial microcysts, epithelial vacuoles, epithelial bullae, and dimple veiling. I'll show you some examples of some of these. And this may predispose to infection, and the management is to optimize lens fit, therefore avoiding a flat fit, and if necessary, abandon extended wear altogether. So we move on to the conjunctiva, and we can have staining, which can be diffuse or around the lens edge. We can have hyperemia or redness, which can be due to hypoxia and hypercapnia. That means retention of carbon dioxide. And you get this condition called contact lens associated red eyes, which is a loose term, and the eyes just go red. And I will show you examples. And when you decrease wear time, improve the fit and improve material, then it disappears. Then I will tell you about giant papillary conjunctivitis as well. So here we have conjunctival compression from a soft lens, which is a little too tight, so you get an indentation. Here you get just generalized hyperemia, and it could just be contact lens associated red eye, of no huge significance, but obviously uncomfortable and unsightly. Here, further examples of contact lens acute red eye or associated red eye. Here is an important topic which I shall dwell on a little bit, and this is contact lens associated papillary conjunctivitis or giant papillary conjunctivitis. And papillae come in different sizes, and as they get bigger, they can coalesce and can become macropapillae or even giant papillae. And how does it come about then? This comes about with deposits on contact lenses rubbing against the back of the lid. Obviously, with each blink, you have the protein material rubbing against the back of the lid, and this is the reaction you get. It's a biomechanical effect. You get proteins and the blink, and it also happens, as you remember, with ocular prosthesis. So if you have a shell, it needs to be polished and cleaned from time to time. Otherwise, with each blink, they can also get the discharge. And also, when you have suture ends, which are not buried, you can also get, or loose sutures, you can get giant papillary conjunctivitis. And once you remove that, then the symptoms disappear. And it's the same with contact lens, where they are comfortable and discharging. But once you stop contact lens wear, it disappears. So what can you do if they still want to wear contact lenses? Well, you ask them to clean and deproteinize more frequently. You can change the material, which attracts less deposits. You can change to a smaller size, so there is a smaller area to rub against the back of the upper lid. You can change to daily disposables. You can decrease the wear time as a last resort, and only in patients who need to wear a contact lens to see. For example, your keratoconus patients, you can use a steroid, but you cannot really justify using steroid eye drops when it's only for cosmetic wear, so that they don't want to wear glasses. It cannot be justified, and it would be wrong to do so. So what about the limbus then? What can contact lenses do to the limbus? Again, you can have reddening from a hypoxia and retention of carbon dioxide. There can be a mechanical pressure, and there can be toxicity from various contact lens solutions. And also you can get superior limbic keratoconjunctivitis, SLK, which is similar to Theodore's SLK. With a scleral lens, here's a scleral lens, not full size, but quite large, you can get compression of the limbus and surrounding conjunctiva. And here you see SLK. Now, what about the cornea itself? In the epithelium, you can get mosaic, 3 and 9 o'clock staining, dimple veil, inferior arcuate lesion, superior epithelial arcuate lesion, acute epithelial loss, usually from overwear or sleeping with lenses which are not suitable, microcysts, edema, vacuoles, bully, and wrinkling. Let's see some examples. Here you see this mosaic pattern, and actually you see that even without contact lens wear, if you rub your eyes and they get and the pressure goes down a little bit, and you put some fluorescein in, you see this pattern. It's called Fischer-Schweizer appearance. And then you have 3 and 9 o'clock inflammation. There's actually more 4 and 8 o'clock. What happens is when you have this contact lens, it is slightly raised, of course, and when the lid blinks, then it misses out an area here because of this thickness here and here, and you get staining and inflammation. So it's called 3 and 9 o'clock inflammation. You can increase the size of the contact lens or change to a soft contact lens, then this will disappear. The staining with fluorescein. Now, dimple veil is when you have little air bubbles underneath, and then when you take it off, then you will see a staining in the same pattern. You can have epitheliopathy from solutions as well. And so if you change the solution or you change to daily disposables, then it will improve the situation. Here's a more serious example of solution-induced epitheliopathy. So no lens wear and antibiotic cover, and they will improve. So what about the stroma of the cornea? You can get edema with a longer term of hypoxia and hypercapnia. Then you can get thinning of the stroma. You can even get deep opacities and vascularization, either superficial or deep. And deep usually is from hypoxia. And you can get these sterile ulcers and sterile keratitis. And of course, you can get actual infective keratitis. I've shown you some examples already, and we will just quickly look at some examples. So you can see that the limbal vessels are going further in, and these vessels should be closed loops. And if they're open and they start to show some infiltrates, you know they're active, and you know that maybe they should stop wearing lenses for the moment and let the corneas recover a bit. And here are the vessels going in, and these are still not very deep, but already a bit deeper in the stroma. And peripheral ulcers, and on healing, it forms a tiny scar of no significance when it's very small, peripheral, and without any anterior chamber activity. But if in doubt, then scrape and plate just in case. And here you have Pseudomonas keratitis. And here you can see sometimes the contact lens cases can be so dirty, it's incredible. And here you have acanthamoeba and the epithelial irregularity, sometimes misdiagnosed as herpes simplex keratitis. And further on, you can get ring-shaped ulcers from acanthamoeba. And Candida, Fusarium. Okay, so I think sometimes contact lenses is for recreation, is not even for correction of myopia, and sometimes their hygiene is not great. And there is a fad of wearing colored contact lenses and pattern as well. And the problem with this is that they really have very low oxygen permeability, and so they can cause harm. Here's an example to very amazing appearance, but it's not so healthy. So carry on with the endothelial, with endothelium. You can get blebbing from acute overwear, long-term wear. You can get cell loss, and pleomorphism, meaning variability of shape, and polymegathism, variation in size. And this is very often misspelled. People spell this with an A. It's wrong. It should be an E. So all caused by hypoxia and hypercapnia. Here you have a normal endothelium of a 9-year-old or 9.5-year-old, hexagonal in shape, many cells, and regular. Here you have acute endothelial blebbing, and these dark areas, they just kind of pop. And pleomorphism and polymegathism, so you can see the variability in shape, losing the hexagonal structure, and variation in size, large one, small one, large one, large one. And that's called polymegathism. So there is some cell loss, but the change of shape and variation in size, we don't know what the clinical significance is. And in the olden days, you would draw them and then analyze them. But modern machinery with computerized analysis can give you indices much more quickly. So I think it's important to understand the cornea really needs oxygen, and it gets some of it. The posterior cornea gets it from the aqueous, but the front of the cornea gets it from the tear film, and the tear film gets it from the outside oxygen. And so when you have a contact lens on top, it's not just the oxygen permeability of the material, it's also how thick that particular contact lens is. So you've got this thing called dk over T. So the transmissibility of the material, but also how thin it is. It is important to understand this. So since 1984, new contact lens materials have appeared which meet the Holden and Mertz criteria of highly permeable rigid materials to make corneal lenses and scleral lenses. And silicone hydrogel soft materials, they have very high oxygen permeability. And when we use a bandage lens, we still often use just a hydrogel lens, which still cause hypoxia when the eye is closed. So one does wonder whether it's wise to asphyxiate a sick cornea and whether we should not move to the more modern material. So I think we have covered this already. And so I acknowledge again huge borrowing of images from Andrew Gasson's book, which I can recommend to you, and many years of tutelage from my one of my mentors, Professor Roger Buckley. Thank you very much for your attention. And if you have any questions, I am happy to take them.
Thank you very much, Professor Liu, for this very interesting overview. It was very informative and very simple. And of course, I would like to welcome Professor Mohammed Husni, who joined us as well. And I want to open now for discussion and for questions.
Hello, everyone. Hello, Professor Lou. Always a pleasure to hear you. And I admit, I plead guilty. I've been writing polymegathism with an A for the past 25 years. So I'm sorry about that. So thank you, sir, for correcting this piece of information for me. This was an uh, this was an amazing presentation, and actually covering the basics. Sometimes we go into deep, sort of top-notch science and the basic practice of ophthalmology, especially in this part of the world where we do not have. I'm speaking about Egypt. We do not have trained optometrists and eye care professionals apart from ophthalmologists. So actually, we do have a generation now of doctors that know how to treat very advanced diseases of the eye, but they don't know how to handle a simple contact lens problem. And they are the persons that are responsible for prescription of contact lenses, for following up the contact lens patients. And when I say that, I'm not saying the patients that do have advanced corneal diseases or post PKs or whatever. Even the normal contact lens, soft contact lens population are not cared after properly in this part of the world, for the simple reason that no one of the junior colleagues invest a lot of time learning the basics. So I think the value of talks and lectures like the one that we just heard is very high. Is very, very high. And the young ophthalmologists spend a lot of time reading about polypoidal choroidopathies and stuff like that, but then they cannot handle their patients who is a contact lens wearer with no corneal problems. So thank you, sir. This was a very good and very, very beneficial talk. So I don't have any questions, but if you'd like to fish for questions in the Q&A, Professor Sinjab, then go, please.
Thank you very much. Great. Now, before I start the questions, I would like to ask Professor Lou. Now, if I'm using the contact lens for a patient, for example, for a corneal abrasion, large corneal abrasion, especially if it is associated with a hypo or low sensitivity of the cornea because it is recurrent and so on. And this patient develops complication of the contact lens itself. So how to deal with this problem? Because we need the contact lens and we cannot use it, or we have to stop using it. So how can we deal with this problem?
Okay, can you hear me?
Yeah, sure.
So I think maybe the scenario you're describing is, for example, an indolent epithelial defect which wouldn't heal, either because the ocular surface is poor or some degree of limbal stem cell problems, or dryness or hypoesthesia. Then actually maybe it is best to avoid putting a contact lens in place and instead really reduce the medications, take out all the preservatives and use unpreserved ointments, and if necessary use serum tears, and if really necessary even do a temporary tassorrhaphy or Botox to lower the lid. Because I think in sick eyes, it's probably best to avoid contact lens. I mean, I say this, but I mean, I see it happening all the time that contact lenses may be, not used in the best possible way. And Professor Hosni is right, because contact lens is not sexy. So people don't really want to know about it. If you talk about lamellar keratoplasty or LASIK or femto this, that, or the other, then that the young people, the ears prick up and they, oh yeah, really, I want to learn all about this, and they very quickly learn about this. But contact lenses is kind of considered boring. I don't know. It's the same in England. I don't know how we can deal with this. They're not very interested.
Yeah. But the difference between England and our part of the world is that in your part of the world you have optometrists and opticians. In Egypt, no one is allowed to do this except ophthalmologists. So we seriously have a problem. We do have a generation of ophthalmologists, of good ophthalmologists, that number one, they cannot refract the patient properly, and they cannot deal with contact lens problems properly. So I think this is something that we have to stress upon in these settings when we're doing like a course, a webinar, or something aimed for our younger colleagues. I think we should. This talk, honestly, was very, very, very called for.
Well, thank you again. But how about including it in the syllabus and including in examinations as well? So maybe that would force people to study it.
Yeah, yeah. Definitely so. Definitely so. In our university, I'm a professor at Cairo University, and I'm one of the people who organize exams. So I insist on putting a lot of refraction, good old retinoscopy in the exam, and I'm considered the bad guy. The young the young residents dream nightmares about me because of the retinoscopy thing. So I think yes, putting these stuff into exams will force the young generation to read about them. But again, it is an art, and it is something that you have to have it in your back pocket, and you will definitely need it every now and then. So yeah.
Yeah, so in the UK also, the trainees are not keen on refraction examination, but us older people, we're always insisting that it should not be abolished, because they keep saying that why do we have to do a refraction exam? And as you know, we have been invited to go to Egypt to start co-examining. So I think we're starting with refraction maybe in March of next year, and hopefully the FRC off clinical part in March of 2023. So and the contact lens is in the syllabus, I'm afraid.
I passed my optics and refraction module in Bristol back in 1997.
Oh yeah, I also passed my FRC off in Bristol in the first exam. That was a long time ago. I think it was 1989. Right, so let's have a look at these questions. Steroid infiltrates. Can topical steroids be given? Well, topical steroids can be given to anything, but it's not recommended. I think if you give some antibiotics, it will go away. Another question, please. Epitheliopathy secondary to contact lens, is it different from early acanthamoebic infection? Well, you can't actually always tell what's what from the appearance. So think of the symptoms as well. And if you're not sure, then observe closely. And if necessary, do your epithelial sheet biopsy. If you have access to a confocal, then you can also image to see whether you can see any cyst or trophoceros. The interpretation is actually very, very difficult, but it's worth a go. Is there any rule to use artificial tear gel before the use of contact lens? No, but I think if you trap some gel underneath the contact lens, then maybe there'll be some blurring. There is a rule in using eye drops with contact lenses, that is preserved eye drops. The preservative, in particular benzalkonium, will be concentrated in the soft lens material. So unless the lens is daily disposable, then you should not use preserved drops together with contact lens wear. So if you need, for example, you need to use anti-glaucoma drops, then it's best to use them like before you put the contact lens in. For example, if you use Ganfort, or if you use latanoprost at bedtime, then take the lenses out first and then use the lens. So those are the guiding principles.
Yeah, there are some other questions. Why should we stop the antibiotic for 24 hours before re-scraping?
Okay, re-scraping.
Re-scraping, provided that, yeah.
So if you're worried that after the first scrape, which, for example, doesn't show any growth, and then they're already on ofloxacin or getafloxacin or moxifloxacin, and there's no improvement after 2, 3, 4 days, and you think, oh dear, have I got it wrong? Is there something else, the problem? Then if you scrape straight away, re-scrape straight away, because the antibiotics have been beating up the bacteria so badly. So even if they haven't been killed properly and the disease is still there, they have been battered so badly that if you scrape, they will not really want to grow on your agar or blood agar or chocolate agar plate. So if you stop the antibiotics for 24 hours, then the bacteria can become a little bit more alive and healthy, and you might be able to grow it better. And then you might be able to know what you're dealing with. That's the reason for stopping for 24 hours.
Great, thank you very much. Now, what is the treatment, the best treatment for erosion due to contact lens, be it traumatic or after acute hypoxia? And is there any role for the steroids to be used in such cases?
Okay. So I think one thing to remember is with soft lenses, unless the fingernail has scratched the cornea, soft lenses do not create corneal abrasions. So if there is an epithelial defect, your first suspicion should be the beginnings of a corneal ulcer or infectious keratitis. Steroids are very much misused all over the world. And also, you know, even my very dear colleagues, sometimes I think, oh my God, you know, what's going on here? And if people go back to my first talk, I did mention, you know, the very common times when steroids can be misused. So I think steroids, the less the better. And, you know, even if you're trying to reduce the scar of a corneal ulcer or bacterial keratitis, the studies show you that eventually it will be the same scar. But on the other hand, if you're using steroid, you run the risk of reactivating the infection, especially with gram-negative bacteria. So why bother? You know, I think it's better to be safe.
But I think the story is different when we do the PRK. Is that right?
Of course. I mean, if you do PRK, then you do need steroid to control the inflammation and activation of the keratocytes. And also people talk about not using anesthetic drops because it slows down epithelial healing. But when it's so painful after PRK, you do need to have the anesthetic drops and it will heal eventually. So yes, of course, that's different. But with normal contact lens, if you get an epithelial defect, you should not assume it to be an abrasion. You should assume it to be an early infection. Now with PRK, then yes, of course, you put a contact lens on to act as a splint to encourage epithelial healing. And yes, you do need the steroid and you need the antibiotic. And sometimes you need anesthetic drops as well. Of course, that's different.
Thank you. Now, there is a case in which a patient developed a bilateral and large corneal ulcer one day after using a contact lens. So what do you think the cause and management of bilateral large corneal ulcer?
So are we talking about infectious keratitis?
Mm-hmm.
I think that's just bad luck.
Yeah, bad exactly.
Luck. We still have to go through exactly the same thing, and we have to scrape each eye, and put the drops in. And if it's large, then obviously you might actually go to fortified cefuroxime and gentamicin straight away, rather than just use fluoroquinolone as monotherapy. And you probably need to admit them and do the drops round the clock every hour. And when you're using two different types of drops, then on the hour, then you might be using one, and 5 minutes past, you use the other one. So at night, they get 55 minutes of sleep. Otherwise, they get very, very tired. If you do one on the hour and the other half past, then they get very little sleep.
And Yeah, thank you. And maybe it is bilateral, maybe because the patient is immunosuppressant, maybe diabetic, maybe. What do you think?
Oh, well, okay. I mean, you would investigate the patient, of course, but I wouldn't read too much into it. There might also be bilateral ocular surface disease, which predisposes them to bacterial ulcers. And also, you know, their personal hygiene may not be great. They may be a farmer with very dirty fingernails. Who knows?
Yeah, exactly. Now, in this case, do you recommend do the scraping, two different scraping, do two different plates, two different homework separately, I mean?
Yes, the same patient, but two separate eyes, and
Yeah,
separately. They might even be infected with different agents. Who knows?
What is the maximum time that we can keep a bandage contact lens inside the eye before we replace it again?
Okay, so a bandage contact lens. Sorry, my clocks are going like crazy. I've got 5 clocks in my consulting room. So I think a bandage contact lens, when you're trying to put it on to splint the epithelium, firstly, once you've put it on, you should assess the fit after 1 hour, because the lens shape equilibrates with the tear and the eye. And rightly, you should also examine them on day 1. Most bandage lenses would last 1 month before they need to be replaced. Sometimes sooner. You can see it becomes uncomfortable and you got deposits. However, in some cases, they don't actually need to be replaced for even 2 or 3 months. So you see them and then you judge according to the symptoms and cleanliness of the lens. But if you want to examine the cornea properly, you will have to remove the lens. And if you remove the lens, maybe you want to put a new one in rather than clean it and put it back in. So that's the story. Yeah. And of course, you know, you've given me the brief that the morning thing later on this year, I have to tell people all about recurrent corneal erosion. So maybe we should save some of that for them.
Do you routinely prescribe lubricants for contact lens users on all types, like the rigid one, the scleral, the extended wear, the soft, all types?
Okay, so I mean, as Professor Hosni said, the majority of contact lens practice is done by optometrists, and there are specialist dry eye products for contact lens wear. But you know, nowadays we have so many different unpreserved hyaluronic acid dry eye products. So those are also suitable. You can use them with contact lens wear, it's not a problem.
Now, I think last 2 questions. One is, can we use bandage contact lens in contact lens induced corneal ulcer to enhance healing?
Okay, so a contact lens would not be indicated. In fact, it's contraindicated because you are stopping the antibiotics from reaching where it needs to go. There may be exceptions, you know, people experimenting with contact lenses which are pre-soaked with antibiotics, but with infectious keratitis, you want to leave it open for it to breathe and also for the drops to go in. Now, I have seen people patch the eye as well, and you are then incubating the bacteria. And if it's Pseudomonas and you incubate it, within a day or 2, your eye could perforate. And I think then in Arabic is khalas. Finished. Okay. So no contact lens and no patching.
No. Another question, if we have an infectious keratitis with a huge and deep epithelial and stromal defect with a risk of perforation, can we use a contact lens?
No. Even worse, isn't it? No. I think you'd be watching very carefully, and if it starts to perforate or if it's out of control, you might be forced to do a therapeutic penetrating keratoplasty, even when it's inflamed and hot like that, because you don't want to do it, but sometimes you have to do surgery when the conditions are not favorable, just to save the eye.
Of course, I want to thank the audience for raising such questions, because as Professor Mohammed Husni said, many ophthalmologists think that contact lenses are a magic solution for everything regarding the cornea. So we learned from you, Professor Lou, today that, of course, there are guidelines, there are rules that we have to follow. Otherwise, we will be complicating the case of the patient, and maybe the eye will become khalas.
Yes, very true. And people don't recognize that, and they think that, well, I've done everything possible, and they don't even realize that they have actually added to the problem. So sometimes we have to just close our eyes and examine our souls and see whether we have actually been the good people we think we have been.
Of course, there are guidelines, there are rules that we have to. Thank you very much.
Thank you.
From where?
Don't know. Well, it's very nice seeing all of you, and until next time.
Yes, sure. Thank you, Professor Lou, and thanks to Professor Husni. Thank you for the audience, and have a good night, everybody.
Good night.
Good night, everybody. Bye-bye.
Bye-bye. Assalamu alaikum.
Assalamu alaikum.